Rachel, I will pass over to you for introduction. Thank you very
Okay.
much.
I will briefly introduce our speaker. Thank you all for joining. We're very excited for this month's NETChatter event. This month, we have a returning speaker, but it's been a while since we've heard from her. Dr. Nagla Karim is back with us to give us updates on thoracic neuroendocrine tumors, the current and the future perspectives. Just briefly about Dr. Karim, she's a medical oncologist in Washington, D.C. She received her medical degree from Cairo University School of Medicine, and she's been in practice for more than 20 years. Her focus is
30.
on lung
Thir-
cancer, clinical and
30.
translational research, as well as phase 1 clinical trials. So we're very excited about her updated talk. And Dr. Kareem, the floor is yours.
Thank you so much. It's 30 years, but whatever. I look young, so it's fine.
There's no way you're more than 30 years old.
I graduated 1993. I cannot imagine life just goes on
I'm
very
so
quickly.
impressed.
Thank you. So today I'm going to talk about thoracic neuroendocrine tumors, but however, I'm focusing so much on the aggressive type. Unfortunately, but fortunately, because now we have more treatment options and more hope to give to our patients. Unfortunately, of course, because it's aggressive, but it also tells us that we have to work more on our low-grade tumors. Here are my disclosures. So, thoracic neuroendocrine tumors is not something that we take for ease because it's third of those neuroendocrine tumors in general. Because, of course, we are very much aware of the GI, whether it's, the appendix, ileum, colon, stomach, and all the different areas that can have neuroendocrine tumors, but the lung constitutes like third of those neuroendocrine tumors. So those pulmonary neuroendocrine tumors can be indolent to aggressive. And we always talked about that because basically, even though that when they say lung cancer, everybody's talking about like, the lung cancer, the aggressive forms. However, 2% of all primary lung cancers can have those neuroendocrine tumors, and they are run in a spectrum for the diffuse idiopathic pulmonary neuroendocrine cell hyperplasia only to typical carcinoid, atypical carcinoid, large cell neuroendocrine cancers, and small cell lung cancer. And small cell lung cancer, the latter that I'll, be focused on because these are repetitive, but because unfortunately we don't have so much new, we are building new clinical trials that are on the way to come for those low-grade tumors. So stay tuned, but they don't have the results yet to present. So the hyperplasia that I just talked about, this generalized proliferation that can happen in pulmonary neuroendocrine cells, that's the first degree. And it's one half of those patients basically have this very well differentiated tumor, and it's not associated with any incidence of small cell lung cancer. Most symptomatic patients present with cough, breathlessness, wheezes, and they become misdiagnosed as asthma. But you always want to have those pathology to know that these are types of precursors for pulmonary nets or the carcinoids. So getting into typical and atypical carcinoids and getting into the poorly differentiated types, those well differentiated types have low mitotic rates and low Ki-67, the proliferation rate. They are well differentiated. They have uniform cells and abundance of granules because they do have time to form those granules. So they exhaust their time forming the granules, so they're not as aggressive, they're not as malignant. However, the poorly differentiated, they have high proliferative rate, high mitotic rate. They're very abnormally looking. They don't have time to make granules. They have less granules. They have very irregular nuclei. And if you look, this is the well differentiated. They exhaust their time more differentiating those cells. However, this is the poorly differentiated because it doesn't have time. It's very aggressive. It's coming very quickly. So it just keeps on like it's very disorganized. So let's do it this way. For the typical and atypical carcinoid, they occur like in the sixth decade of life. The large cell neuroendocrine tumors and small cell tumors, they occur later in life, like in the 70s. And basically, women tend to have more of the well differentiated time. type. The men needs like it's more of the small cell and large cell neuroendocrine differentiation. Smoking is more associated with the more aggressive type. And then, of course, the mitotic and the necrotic and all that is more associated with a poorly differentiated high proliferative rate, as I mentioned. All of them has the synaptophysin and chromogranin and the CD56 positivity, almost all of them. Combined with non-small cell lung cancer, more often happens with the poorly differentiated or the small cell lung cancer type. If we're talking about well-differentiated type, surgery is the mainstay of treatment, whether it's wedge resection or lobectomy. It depends on the size. It depends on how, it's behaving. SBRT, which is, something new now, but sometimes patients who are not candidates for surgery, they can be considered to be radiated for those even well-differentiated types. What about the advanced bronchopulmonary? Because it's inside the bronchi. Everolimus is the only FDA approved agent for those bronchopulmonary neuroendocrine tumors. Temozolomide alone with capecitabine can be recommended. Again, we do have clinical trials that are in the progress of building. I don't have data to present on them now. I think they're still not open to the public. But basically, just to summarize that those atypical carcinoids, especially if they become very aggressive and we're not really able to control them, sometimes I have those patients. We treat them like small cell platinum etoposide. If they're more indolent, of course, the temozolomide with capecitabine, 5-FU, dacarbazine, capecitabine combinations, painful bone metastasis can have radiation. That's basically looking at that, but there are ongoing studies for everolimus, for lanreotide, the temozolomide capecitabines, dotate. Basically, one of the newer ones would be with the IOs, with the pembro, nivo, epi, and so on. However, those studies, they have shown overall response rates that are not very high, like maybe 33%. But that tells us that there's always been a struggle having dedicated thoracic neuroendocrine tumor, sort of like studies, because those patients are not, present everywhere. So we would really want to have more awareness. So patients with thoracic neuroendocrine tumors, the well differentiated, can enroll in studies because we don't have so many treatment options that are available unless we have a clinical trial that can show us progress in this disease type. For large cell neuroendocrine carcinoma, this is poorly differentiated. This is more aggressive. This is not just carcinoid or atypical carcinoid. It's present in 3% of the lung cancers. It gets into the seventh decade. Basically, half of those patients present as metastatic to start with. So it's not a good tumor. The worst part of the large cell neuroendocrine is that there is a dilemma about how to treat it and how to diagnose it. Basically, for the WHO classification, they classify it as a thoracic neuroendocrine that has a high proliferative rate, maybe not as high as small cell, but still it doesn't respond as well as small cell lung cancer to chemotherapy, which makes it very, you know, like indolent, but at the same time, not a very favorable tumor. Mixed large cell neuroendocrine tumors can happen. Some people can have mixed with non-small cell lung cancer, squamous or adenocarcinomas. At the same time, they have TTF1 positivity in about half of those patients. But basically, the morphology here of large cell neuroendocrine displays this organoid nesting and a palisading pattern, which has, still eosinophilic cytoplasm, coarse granular chromatin, prominent nucleoli. Maybe it's better differentiated to small cell, but it's still aggressive and more aggressive than the well differentiated types. The large cell neuroendocrine tumor can display small cell lung cancer phenotype and biologic behavior, because basically, if you look at those patients, you find the survival less than 10% of the 5 year. So that's why it's not a favorable disease. It has higher FDG uptake compared to the well-differentiated thoracic neuroendocrine tumors or neuroendocrine tumors in general. It is thought to be having higher expression of glucose transporter 1. Those patients present basically with a peripheral tumor. Remember, small cell, it's always central. Squamous cell carcinoma is always like S with S, like central. Large cell neuroendocrine tend to be a peripheral tumor, so it's less likely to cause those hemoptysis or dyspnea. It can show up with metastasis to start with, and it's slightly higher percentage to have brain metastasis. It's basically like small cell lung cancer in that category. But to compare the large cell neuroendocrine, it's rare. It's less common than small cell lung cancer because it's only like, as I mentioned, it's only like 2 to 3%. And it is associated with smoking, and it is associated with the TTF1 positivity and this peripheral location. The problem here also is that those large cell neuroendocrine tumors have a problem giving a diagnosis based on fine needle aspiration. So those patients tend to have the diagnosis. It has to be a core biopsy because the core biopsy can give us more information about the proliferative index, the Ki67, the mitotic index, about how the tumor looks like, as a whole, rather than just like an FNA. So core biopsies are preferred to diagnose patients with large cell neuroendocrine tumors. I think nowadays they have better ways to look at those patients. Looking at the transcriptomic or the subtyping for those patients, it's very, very interesting that you find that the large cell neuroendocrine tumor, some of them have characteristics, genomic profiling that is similar to small cell or not similar to small cell. So why do I say that? Because some of them have high P53 and RB, retinoblastoma expression. So this tends to be like a type 2, and this tend to behave more like a small cell lung cancer type, and maybe suggestive that we should treat it like small cell lung cancer. They still can have those subtypes of small cell of the A subtype, and the high notch and all that, but some of them have less. They don't have as much of those P53 or retinoblastoma. This means that yes, there could be type A, type B. Is this something like determining really for treatment? No, until now, we don't have prospective studies to show if I should treat this way or that way based on those analyses. These are all retrospective studies. So the better genomic classification was also including CDKN2A, B, MTAP. So, more, not just the P53 and the retinoblastoma gene, but like more and more are coming. The SMARC 4A, FGF3. So looking into those, they're trying to classify the large cell neuroendocrine into non-small cell lung cancer like or small cell lung cancer like. Is it applicable clinically? It's something that is still in the works. So how do we manage? Well, early stage, basically, we need surgery. We need adjuvant treatment. Adjuvant, is it like small cell? Most probably, when I see those patients in clinic, I treat with platinum etoposide as adjuvant. This overall survival rate is better, basically, when it's early phase and when I receive some adjuvant treatment for those large cell neuroendocrine tumors. Chemo radiation in node positive status. So I follow like, non-small cell lung cancer or small cell lung cancer because it's based on chemo radiation. So looking at cisplatin etoposide and looking at DART, which included ipilimumab and nivo. Looks like the median progression-free survival when those patients received platinum etoposide, like small cell regimen, it was just median overall survival of 7.7 or 10.2 months. So it's close to like a year. But what about if I'm talking about the DART? So if I'm talking about the DART, they had a response rate like maybe better of maybe like 66% compared to less response rates in others. DART, it only had like 3 patients with large cell neuroendocrine cancer. So can't really say much about, prospective data or large data, but we would like to learn more. So, what about the treatment themselves? Well, pemetrexed in retrospective analysis was found to not to be the best treatment in large cell neuroendocrine cancer because they have higher levels of thymic synthase expressed by this tumor. Large cell neuroendocrine cancer may not respond to platinum etoposide as strongly as small cell lung cancer. So, this really means we need to have our own regimens for large cell neuroendocrine cancer. Nowadays, we send for molecular profiling and we try to look into IO approaches or IO combined therapies. What about the IO combined therapies? Well, if looking at some data, it shows that they do have superior outcome compared to only chemo. What about the STK11 and KEAP1? That has been shown to be something with the KRAS subtypes, and KRAS is in the non-small cell lung cancer. So, but those subtypes for the KRAS, and that's not large cell neuroendocrine cancer, showed that when we do dual IO, so IO plus CT4 inhibitors, they were doing better. Is this something to apply here? Well, we need more and more studies. So there's Durva in combination with carbo, and that's in patients with large cell neuroendocrine cancer metastatic, and atezo platinum etoposide for treatment for advanced large cell neuroendocrine cancer. So these are ongoing clinical trials that we will learn from. DLL3 expression, we're just talking about the threshold, and looks like basically DLL3 is overexpressed also in large cell neuroendocrine cancers and small cell lung cancer. So this means maybe the exciting treatment now in small cell lung cancer may be applicable for large cell neuroendocrine cancer. So as a conclusion, well, we have to look into the IO therapy in large cell neuroendocrine treatment because we don't have the prospective data yet. So I think more and more to go. Unanswered question would be that P53RB, if this is something that we should classify our patients for. What about the immunotherapies? What about the molecularly driven therapies? There were some EGFR and reports of ALK and reports for other targeted therapies that can be present for large cell neuroendocrine cancers. Should we offer prophylactic cranial irradiation? There are more and more studies to look into that. So, improving therapeutic options. Any questions here before I move to small cell lung cancer? Because small cell lung cancer, I'm going to say a lot. So, anything? Okay, if not, now let's move to small cell lung cancer. Is the most aggressive type for the thoracic neuroendocrine tumors. However, for me, I gave more time this time to small cell lung cancer compared to the last talks when I focused on the carcinoids. And the reason is because there's so many exciting events that happened, between the time we met and now. So small cell lung cancer, we know it's the most aggressive amongst all thoracic neuroendocrine tumors. The 3-year relative survival rate is only 12% across all of them. And initial chemosensitivity, yes, it's present. Those patients are going to be sensitive to chemotherapy, but unfortunately, they recur. And when they recur and relapse or become refractory, they are very difficult to get a response and an outcome. So consequently, improving the outcomes in the early stage setting remains critical. So what about the current status? Looking at limited stage small cell lung cancer, where the small cell lung cancer is limited to one hemisphere, basically, it was until very recent that we treated just with chemoradiation, carbo or cisplatin etoposide and radiation. We had a good response initially for the limited stage, and basically some got cured, but not all. And of course, it's better than extensive stage where, yes, we have a response of around 60%, but still, the survival was limited with that 1 year. Well, excitingly, that the limited stage small cell lung cancer recently in this ASCO, those patients were studied in a clinical trial where we know, of course, that the majority are not cured because looking at limited stage, the 5-year survival was only 16 to 26% when we use only chemotherapy and radiation, with a median overall survival of less than 3 years, 25 to 30 months. So the current standard, if someone has a very tiny tumor, T1 to T2 and 0, then they have surgery. It's allowed. And when we give adjuvant chemotherapy with a platinum etoposide, chemoradiation for most patients has been the standard of care. Until, of course, the Adriatic study was presented this past ASCO, where patients basically were randomized between getting, after treating the chemoradiation, we're getting Durva as a consolidation for those couple of years, or plus placebo. And of course, the third arm, but it's not analyzed yet, having the Durva plus Tremi. So it was fantastic. This is the first time for a very long time that the small cell lung cancer, the limited stage, the overall response, the overall survival was, when using the consolidation 2 years of durvalumab, was 55.9 months median, compared to only 33.4 months in the placebo arm, which has been the standard of care before, knowing those results this past June. Hazard ratio was 0.73. Fantastic. So, of course, you can see the difference. The curves are well differentiated. The progression-free survival, because it was a dual primary endpoint, median progression-free survival was 16.6 months compared to 9.2 months only in the patients who did not receive durvalumab consolidation. The adverse events, we know about the autoimmune side effects. We're pretty more comfortable treating patients with IO right now. We look into the pneumonitis, we look into the diarrhea, the rash, all the autoimmune side effects, the thyroid, hypothyroidism. It wasn't that significant, we follow those patients, but radiation pneumonitis has been 22.9 versus 23.4 percent, so it was manageable. So as a conclusion, Durva has become the new standard of care for limited stage small cell lung cancer who have not progressed after chemo radiation. The Adriatic study, of course, included a subgroup of patients who received prophylactic cranial irradiation, showing prophylactic cranial irradiation is better. However, this is not the end of the world, because we still have the PCI, the Maverick study, the 1827 SWOG study, that is looking now as we speak prospectively at patients who are going to receive just surveillance MRI, or they're going to have prophylactic cranial irradiation, looking at neurocognitive, looking at overall survival. This is going to be stronger because it's a prospective analysis for this group of patients rather than getting just a retrospective look at those patients. So what is really emphasized here is that when we used the IO early on in the limited stage as a consolidation, not with the radiation, after the chemo radiation, we have very good benefit, increasing the overall survival from 33.4 to 55.9 months. And this is so important because when we look at extensive stage disease with the Empower 133 and the campaign, the benefit was only 2 months. So looking at using the IO early on in the consolidation with limited stage, looks like the benefit is going to be much better than waiting until the patients are really advanced in their disease to get only the 2 months of benefit. Same like Pacific study with the, stage 3, they got like a good median overall survival of, 47.5 months compared to 29.1 months. So it's always good to work on those early detections. The future approaches, well, we don't know if everybody is going to be the same because there's still A subtype, N subtype, P subtype, and looks like limited stage small cell lung cancer is enriched with the inflamed subtypes, P subtype and I subtype. So maybe they can have more benefit of IO because they have more inflammatory cells in the early stage of small cell lung cancer. Does sequencing matter? Well, sequencing matters because we had the LU005 study. When those patients, when they were receiving the chemo radiation together, they gave them the IO at the same exact time. But guess what? It was not good at all. They had no difference in overall survival or progression-free survival when using the immunotherapy together during the chemo radiation. Tells us here, if you get Adriatic, you get the maximum benefit of those 2 years, of course, 68%, and median overall survival 55.9 months. But if you look at the LU005, when they use the IO during the chemo radiation, early on, still limited stage, but it's only 39.5 months, exactly like the control arm. So sequencing matters. Okay, so what's next? Next would be the extensive stage small cell lung cancer. Well, the good news is that yes, compared to 30 years ago, at least we are using carbo-etoposide atezo or carbo-etoposide durva for the Empower 133 campaign. Other IOs have been serplulimab and others have been used and they should also benefit. These are the most widely used, FDA-approved agents. So looking at Campaign, continued median overall survival benefit, 3 years data, 12.9 months compared to 10.5 months only if not using the Durva. Umbrella, it was an extension for the Empower 133 because they wanted to look more and more for many more years. Median overall survival continued to benefit, 12.3 months compared to 10.3 months median overall survival when they looked at the 5-year follow-up. But does one size fit all? We don't know. We still need more information for small cell lung cancer because in the non-small cell lung cancer studies, the LAURA, the ADORA, the ALINA, it's always good whenever we find a target, early stage, later stage, it's always good if we get the adjuvant, and so on to help us facilitate. What about the biomarker-driven small cell lung cancer studies? So I'm so honored that our study, the S1929, it was quoted in the plenary session this past ASCO as well, because as we have success in non-small cell lung cancer, we would like to see the same for small cell lung cancer. So what is happening here? Well, looks like, like people are having a difference, but not that much. We're not really selecting the patients to look at that. What about the predictive biomarkers? Well, it seems that maybe there could be subtypes that the inflammatory can have, something to do with the IO therapy. We still need to learn more. Okay, so let's get into my favorite part of the talk because that's what I presented in ASCO in 2023, where we presented our biomarker-driven small cell lung cancer prospective study. We looked at small cell lung cancer as having a high PARP expression level. So that's why if I get a PARP inhibitor, that might be something that will be good for us, So why not? So talazoparib at that time was the most potent. Nowadays, of course, there's more third generation PARP inhibitors and so on that started to come. But at that time, it was the most potent above all PARP inhibitors. And not only that, we were looking at other studies that used a PARP inhibitor, velaparib, and temozolomide, and patients who were Schlafen-11 positive, and that basically through the immunohistochemistry, that's a marker to say the platinum sensitivity and PARP sensitivity. Those patients with Schlafen-11 positivity, as you see here, positive status, they had a higher survival rate of 12.2 months compared to only 7.5 months when treated with a PARP inhibitor, velaparib, with the temozolomide, compared, of course, if they're not getting that. So how to incorporate this strategy? We did not want to give all 4 drugs up front because of toxicity. So we basically built the phase 2 randomized study to give maintenance atezolizumab plus atezolizumab and talazoparib in patients with extensive stage small cell lung cancer. So basically, patients would be treated with the platinum, etoposide, and atezo. First cycle can be okay without atezo because they could be hospitalized, but at least 2 cycles should have the atezo and 4 cycles maximum. And then patients would be tested for the Schlafen-11 during that time. If they're positive, they'll be included in the study as long as they're not progressing. So they will be randomized to either receive Arm A, standard of care atezolizumab, versus Arm B, atezo plus talazoparib. We had 324 samples submitted, where 80% of those samples were evaluable. 70, well, anyways, positive samples, 79% of everybody were positive for Schlafen-11. 21% of all patients were negative for Schlafen 11. It was 7 days. It took only 7 days to be able to get those results and assign the patients for treatment. It was a positive study. We first reported to ASCO a 5 months, survival outcome for progression-free survival, which is the primary endpoint, and it was 4.2 median progression-free survival compared to 2.8 months, and it was a positive study with p-value 0.56 and hazard ratio 0.7. For the overall survival, it did not have statistical significance. Just basically, progression-free survival was the main thing. However, we just reported for Journal of Thoracic Oncology, if you want to look, it's out now, that it's still statistically significant. However, it went down after 1 year. So after 1 year, still the atezo plus talazoparib has 2.9 months, closer to 3 months, median progression-free survival. But that's, of course, after you finish the induction. Atezo by itself was 2.4 months. So those patients basically, have a positive study, but still, we want more potent PARP inhibition. We want more potent predictive biomarker. The little bit like 0.2 months difference, but it's not statistically significant with the overall survival. Patients who got prior radiation basically were the ones who prior thoracic radiation were really benefiting so much. So if you look at the subgroup analysis, progression-free survival for those 13 patients, 5.5 months compared to only 3 months in patients who got atezolizumab alone. The progression-free survival did not make any difference for patients who did not receive thoracic radiation. Overall survival not reached with the experimental arm, and 8.5 months in the atezo alone arm. So this means that we basically, have a difference if we give thoracic radiation for those Schlafen 11 positive population of patients. Anemia, thrombocytopenia were the most common toxicities as expected with talazoparib. Others like, anorexia or, sort of like hyperglycemia, ALT, and so on, they're pretty similar between the two arms, but that's something that we look at. There are other current studies with the PARP inhibition involving temozolomide and durva and olaparib and other, sort of like ongoing studies. But basically still, looking forward to those results. So the subtypes have been also looked at and incorporated with the Schlafen 11 in the PRISM study. That it's not active yet, but it's the next study that is going to be led by another group of investigators within SWOG also. But they basically got the subtypes together with the Schlafen 11 and looking into also the same thing, PARP inhibitor and IO. And of course, we have data, preclinical data, Schlafen 11 negative are going to respond better to the ATR inhibitor, and we'll go from there. What about the relapse or the refractory? It's never too late to try to have better improvement. In the past, we had topotecan, which had median progression-free survival of 2.8 months when using topotecan, and median overall survival of 5.4 months. Lurbinectedin became approved after that, with median progression-free survival slightly better, 3.5 months, and overall survival much better, especially for platinum-sensitive disease, of 9.3 months, with the estimated survival at 6 months of 67.1%. Tarlatamab, I'll talk about it a little bit. It's newly approved, and basically it allows 4.9 progression-free survival, and 68% of those alive at 9 months. Estimated 6-month survival is 73%. Sacituzumab is very promising, coming up with median overall survival of 13.6 months and median progression-free survival of 4.4 months. So slowly improving, but basically this is what we are trying to look at. So that's lurbinectedin. It's a selective inhibitor of oncogenic transcription, acting through the IL-6, IL-8. Basically, it also has inhibition of the immune response, and it's basically another chemotherapy because it works through the induction of tumor cell proliferation. So basically, overall response rate, especially with the cisplatin sensitive was 41%. The refractory was 33.7%, and sort of like the Atlanta studies was 25.5%. And as I mentioned earlier, that those would be the accelerated FDA approval happened, and then confirmation happened. Tarlatamab is a first-in-class DLL3. So DLL3 is overexpressed in small cell lung cancer. And tarlatamab is a bispecific T cell engager molecule binding both DLL3 and CD3, leading to T cell mediated tumor lysis. They had a study where looked at 10 milligram and 100 milligram. Not necessarily that you have to give a high dose to be the best, but anyways, the 10 milligram was really good. So the primary endpoint was overall response rate, and secondary endpoints with the duration of response and all the other survival parameters. Well, the 10 milligram also included the 91 patients. As you see, responses were observed regardless of the DLL3 expression, as well as in patients without evaluable tumor. um, the objective response rate, whether it's 100 milligram or 10 milligram, then basically it's really 39% or 21%. Stable disease was present in those patients, and the median duration of that objective response was not reached, but basically it's around the 4 to 5 months, and objective responses continue to be durable for more than 9 months. Toxicities, cytokine release syndrome is the major factor here. So we have to look into the severity, we have to look into the seriousness, all the cytokine release, also the ICANS, where those patients can have neurologic toxicities, even grade 3 severe toxicities can happen. So we have to basically keep those patients in the first couple of cycles to look into that. These are the data for the phase 2 study, and the tarlatamab had systemic control rate in the brain metastasis, more than 30% shrinkage of brain metastasis. However, those patients already received radiation to the brain lesions and had an intracranial disease control of 14 to 16 patients. Efficacy, overall response rate, it was 51% and 38%. Well, basically for the brain metastasis, 52% if they received that tarlatamab, and the median duration of response was not reached. Median progression-free survival 6.7 months, and median overall survival was 14.3 months. So tarlatamab demonstrated durable response with promising survival regardless of the presence of treated stable brain metastasis at the baseline. So if they got the brain metastasis, they continued to have benefit from tarlatamab. And we just mentioned those adverse events, mainly the cytokine release syndrome and the ICANS. So yeah, just as a repetition, it's the intracranial activity, the 10 milligram dose is the one that's using, and basically it continues to show shrinkage of third of the tumor, more than 30% of the tumor. So what's next? There are more studies on the pipeline combining the durva and tarlatamab in the extensive stage small cell lung cancer, looking into different other topotecan lurbinectedin combinations, looking into targeting B7H3, which is the sacituzumab, the ADCs. So B7H3 play a prominent inhibitory role in adaptive immunotherapy by suppressing T cell activation and proliferation. In addition, it can promote the tumorigenic properties of those tumor cells. So looking at those, basically just back, they got overall response rates of 60%, 50 to 60%, with median progression-free survival around 5.8 or 5.3%, and median overall survival around a year with this patient population. So sacituzumab govitecan, it's basically a topoisomerase 1 loader. Ifinatamab also has been looked at, but these are really very promising. SASI had overall response rate of 49.9%, partial remission like in 18%. The duration of response 4.73 months. Progression-free survival 4.4 months, and overall survival, as I mentioned earlier, 13.6 months. So, open label study. It's really an accelerated look now to get that on board for our patients since it has very promising results. Toxicities, of course, they can lead to discontinuation, but basically looking into febrile neutropenia, diarrhea, looks like our small cell lung cancer patients as a solid tumor more vulnerable for myelosuppression. Ifinatamab, deruxtecan, it also was one of those promising agents, having overall response rate of 26.1 or 54.8% in the higher dose. Basically, the disease control rate was like in 80 to 90%. So as you see here, the progression-free survival, overall survival, it shows benefit, but it's still ongoing in those, I would say early stage studies. Looking at brain metastasis, it also gives very good control for brain metastasis. There are a small number of patients, but it gives us overall response rate of 60 to 50%. There are more first in human studies, sees 6 and so on, because it's more of expressed for small cell lung cancer. Again, it's very preliminary phase 1 studies, again showing different cell lines and showing to have promising responses in small cell lung cancer. There are other types of tumors, but this is basically showing overall response rate 14% and basically partial remission in those 60% of those patients. 2 out of 21 over 23 patients with small cell lung cancer as a third line of treatment, and they were even platinum resistant and still shows a signal of positivity. Again, leukopenia, lymphopenia, neutropenia, thrombocytopenia were amongst those side effects, fatigue, dyspnea, and diarrhea. Cytopenias were dose dependent in this early stage studies. So these are the studies, the landmark. Looks like, the SWOG 1929, it met primary endpoint of improved overall survival. It's a biomarker-based study. So these are all, getting into, the Caspian, the Delphi, the Prism is still coming up. The Raptor is still being stratified. So as a summary, 2024 was an exciting year for small cell lung cancer. Durvalumab is the consolidation now for limited stage small cell lung cancer. We have approvals for tarlatamab for small cell lung cancer, ADCs becoming an option. And to come, multiple active agents are in the relapsed setting being studied. Correlative science and biomarker studies like S1929 are being considered. Targeted therapies. Me and our group of, SWOG and small cell lung cancer team in Egypt celebrating after S1929, of course. More bites and trites, several ADCs. That's from DC. Just trying to thank you, and hopefully the spring comes up very soon. Thank you.
Thank you so much, Nagla, for that wonderful presentation. You were right. There's been a lot of progress, especially in the small cell lung cancer domain, of all of the trials that have gone on and that are, I'm impressed with how much is ongoing on top of that. That was a wonderful presentation. We do have a couple minutes for questions. If anyone has any questions. I have one, but I'm going to save it and see if anyone else does before I jump into it.
I mean,
And
I
then,
want to just say that I'm so really looking forward if the low grade and large cell neuroendocrine give me more data. So I stand here next year. Yes, of course, I'm gonna be celebrating more treatment options for my small cell lung cancer patients, but also those indolent types can have like an aggressive course, because even though it's low grade, but sometimes it can keep coming and it's so bothersome and even, can cause mortality, morbidity and mortality. So I am excited that I'm giving something new compared to the couple years presentation, but I feel like I'm hoping that next year I can even offer more for those early, indolent parts.
I totally agree. John, you had a question. I think it was
Yeah,
John.
yeah, I did. I heard, I don't, I thought somebody else may have spoken too, but anyway, I'll go ahead and ask. And I actually now have two questions. See how that goes. I was curious about, and I didn't get the name. It began with an L. Um, and it seemed to be influencing the tumor immune microenvironment, with well, yeah, with the macrophages. So I was wondering if you could go back to that slide and maybe just briefly go over the mechanism of action. That really caught my attention.
Sure. Which one was that? The
It wasn't Lavatinib. It was something else. Began with an L. But also I can maybe do the video
DLL3,
afterwards.
right?
What's that?
The DLL3. Uh, let's see.
See how long this takes. So
That's
somebody else can go.
Is it the CIS6?
No. I just haven't seen anything quite like it. Now that I am like,
Sure.
it was, yeah, earlier than this.
Tarlatamab? No?
It was before the tarlatinib.
Of course. Lorbenectidine?
Yeah. So
Yes. Sure. Yeah,
it
so
it inhibits the
lorbenectidine.
transcription
Yes. Yes.
of the,
Absolutely, absolutely. So basically, cancer frequently, has this transcriptional disease caused by dysregulated oncogenic transcription factors. So lorbenectidine would basically fight that area for the transcription factors. And basically, instead of going all the way and forming, the promoter, the DNA piece, that can be hindered by lorbenectidine. But in addition to that, it also is associated with down regulation for the IL-6 and IL-8 and basically, having also inhibition for the immune response activation for those immune checkpoints. And in addition to that, also, basically it sort of like crosses this anti-angiogenesis. So it's like with also against the VEGF, IL-8. Sonia, did you want to explain more? I think you raised your hand.
I don't want to explain more.
Yes, of
I
course.
I have a different question altogether, and it's not on the scientific side, but it's really I'm a patient and was first diagnosed back in 2001 with a carcinoid tumor.
Yeah.
At the age of 48, the surgeon at the time said I'd likely had it since I was 17.
Mm.
How many people, because most of the patients that I keep meeting are all adults.
Yes.
How often do you look back further and find that there are pediatrics, or there could have been somebody that was born with this tumor? Because we only ever go forward from the time of diagnosis.
Yes, I totally understand. So in per epidemiology, the low-grade carcinoids and atypical carcinoids tend to happen in younger age. Like in my real life, when I see patients, I can see even 40s, like that with a carcinoid, atypical carcinoid. I've seen younger adolescents and so on with that. For small cell lung cancer, um, even though it says 70s, but I've seen like 50s. But of course, small cell is more of a disease for smoking, pollution maybe, but it's very, very associated with smoking. It tends to appear later in life. Fortunately, I mean, I don't see pediatric oncology, but fortunately, I haven't seen the adolescent or the very young small cell. I've seen non-small cell for younger, like maybe 30s. Um, I'm just saying that, it depends, of course, on the smoking and all that. So those adolescent, maybe like, other types of malignancies, like, the GI and so on. Um, prostate cancer, but it appears later also in the seventh decade that they can have small cell carcinoma of like extrathoracic. You can see like even for breast, some breast cancers they have small cell. So it's different. I think that we are seeing more of older age. Maybe if someone is smoking heavily, younger for small cell, maybe more of the well differentiated appears in the younger age. Pediatric, not very well known. Those patients usually, when I was in Cincinnati, the Cincinnati Children's, they usually consult with us because these are tumors that are more known for older adults.
Okay, thank you very much.
Sure.
Yeah, that's a good question. On the research side, I always wonder, especially with the neuroendocrine tumors, how long have they been growing in a patient? We diagnose them when we find them, but how long have they been there, especially the more indolent ones, that we know grow more slowly? How long have they been there, to then finally be detectable? That's something I think about a lot.
Yeah.
And that's purely on the research side is, when do these things start versus when we finally, when they finally get diagnosed? I wonder if they grow for years. Who knows? It may totally depend on the subtype, I'd imagine.
Yeah.
Well, it's similar to the pituitary tumors. Often patients there, it can take 8 to 10 to 15 years before they're diagnosed. And you think, well, gosh, yeah, you keep going in to see the doctor and you're only allowed to talk about two factors or three symptoms that you've got. But now that I've been diagnosed, when I see doctors, I'll say, now, have you gone back over the records? Have you checked why have I come in so often over the last 2 years? So, yeah.
Yeah. Yeah. That
Tough
tells
one.
me, we got to find a way to find these things sooner.
Yeah.
Yes.
So I think that it is very important for us to have, some programs, especially if we see clusters of patients to ask, you know.
Well, it can also come down to environment. Were you around chemicals,
Right.
agricultural chemicals or things? So,
Yeah.
Yeah. Yeah. There's a whole new realm of research I recently learned about called the exposome. And I mean, other people call me, but it's literally studying things that people have been exposed to throughout their life and how that affects cancer.
Mm.
And
yes.
it's, that they're just starting that. I mean, there's been a lot of research done and other things, but just trying to look at broadly everything you've ever been exposed to could be a really exciting future research, a whole field.
True.
Yeah.
I think this is this is absolutely right because basically it's just something that like it's very important that we take into consideration that things can happen, you know what I mean, but we just don't know. So these things, if they happen, we don't know um, what we can expect. And also, if we don't have a good screening program for small cell lung cancer, we can't really say good numbers. You know what I mean?
Yeah.
The
Do you
problem,
think this is where registries will actually help?
yes. So I'll tell you something very small that I noticed. So when they looked at this registry and they looked at the screening program, they said small cell lung cancer is not affected. However, there is a glitch here because first, they did not really have, for example, consolidation durvalumab to treat the small cell lung cancer, even in limited stage, they still didn't have a good survival. So that's number one. If we don't have a good treatment, even if we do screening, that's not good. But now, if treatment is better, we should really keep looking again about that. Number two is that for small cell also, basically, in the past also we didn't have all those wedge resections, the information about the multidisciplinary team, basically, looking into maybe more sophisticated clinical trials. So they're not really giving the chance to look at it in the screening session well. So I think, that can add so much to our perspective when we look at it now. And of course, the registry, and to get detailed information about smoking, pollution, other exposures, and so on, especially if we're looking at people who are younger in age. Why? Like, even if they're not smoking, is it passive smoking? Is it something else that they're exposed to?
Yeah, definitely. Well,
Right.
we've got about a minute
Right.
left.
Yeah, Rachel, you still want your question?
I can hold it. And I can email her. No big deal.
Okay.
Oh
Okay.
yeah, I'll end up talking for hours. So my
Right. Okay.
scientist brain.
Okay, so we better finish there then. Thank you so much, Dr. Karim. It was a fantastic presentation. And thank you for your questions. Just to let you know that next month we will be starting an hour earlier, and we have Dr. Kate Lyons speaking. And we also will have a very exciting announcement to make next month. So please come and join us, because we're very excited.
Yeah,
It's very exciting. So thank you everyone for coming. Thank you, Rachel, for introducing and running the show as normal. And
I couldn't do it without our speaker, Nagla.
But thank you so much, everyone. And we will see you all again next month.
sure.
Thank you very much. Thank you. Bye-bye.
Bye.
Thank you. Bye.